Yes.
Right.
We good?
All right.
Everything ready to go.
Mm-hmm.
I need to take off.
Hi, Ben. How are you?
But I let you know that
Okay.
if there's any trouble.
Great. Thank you. That's good.
Sure.
How are you doing? So Tracy, what did you do before you worked for me today? Oh, really? Yeah. Were you still working for me today? 11 years ago. So you predate our analysis? Yeah. Yeah. And you're always kind of done with you now, or do you kind of I didn't know. I have been, yeah, I've been with that kind of I was a lawyer before, but I did a lot of other stuff before. I mean, I see. Yeah, I've moved to that area. I've kind of round with president of the model for me. You know, grab your name tag and stuff. That's like yeah, I'm assuming it'll go back to a real empty out front more of it. You should be the first one. Maybe she just shows up at her filling in. Just filling in. She's filling in for us. Working on things, and then I'm going to say what we thought we were going to do.
Good afternoon, everyone. In the interest of trying to end the meeting on time or early on a Friday afternoon, I think we should start. We have few people around the table, so if you introduce yourself for the sake of people who are joining us through the webinar, and then we'll have the work group members from the webinar to introduce themselves. I'm Shulya Chalakolu from HSCRC, by the way.
Claudine Williams, HSCRC.
Linda Bartniska, the Maryland Healthcare Commission.
And Stephan, the Maryland Healthcare Commission.
Gene Ransom, MedChi.
Raquel Sampson, DHMH.
Tracy Laval from the Maryland Hospital Association.
Scott Abzel with CRISP.
Frank Campbell, Health Spring Cigna.
Great, thanks. Anyone who are on the webinar?
Paul Allen, John Hopkins.
We have Andy Fitzsimmons and Stephanie Hurley from Care First.
So we have Steve Johnson and Patricia Travis on the phone as well. Since I don't know if are we going to mute them also because of the echoes? So since there's a feedback, unfortunately we have to mute everyone who are joining on the phone. But Dee Dee is following it closely. So if you want to contribute to the discussion, please, I think, raise your hands. So they're going to unmute you on the webinar. And then we have
Sally Alborn, Maryland Community Health System.
Sally just joined us as well. So before we go into the meat of the agenda, just an update to those of you who weren't here on Wednesday. We presented the report on the data and monitoring gaps to the commissioners on Wednesday, and in general, I would say it was positively received, and commissioners are excited about collecting the total cost of care measures. And our plan on that work is we are going to meet with individual payers separately first to get a better idea about what they do internally, what definitions they use for each, the template, and then bring that information together and have another general meeting with everyone to try to reconcile different definitions and come up with more of towards the final template and data. In terms of timelines, I think those individual meetings are going to happen as quickly as possible, but I would say given we are mid-May and we have other reports that we need to write, I would say a month. And probably towards the end of June, we'll have another subgroup meeting for the total cost of care. Sounds good? All right. The second issue is we modified our draft work plan. So as you notice, we have only one more meeting left. And given where we are with our discussions, what we did is originally they were written as if they were separate reports, but they are all related concepts. So our task is to write one report about the data and infrastructure needs of the care coordination. So, and that will include all the items that we had discussed before. The idea is on the PowerPoint, we try to put as much detail as possible from your comments from the last meeting. And after this meeting, we are going to turn that into a draft report and try to send it to you as early as possible. And when we meet on June 18th, we are hoping that we'll have close to a final report where we can review again collectively and make final changes to it. The other agenda items for the next meeting are the kind of connecting with the other work groups, mainly performance measurement work group and physician work group. They also, you know, when we put these together, we had draft agendas, and they are also in a little different timelines currently. So I don't know by the time June 18 if there's going to be anything from those work groups. So we'll keep you updated on that. And certainly if we can do it as early as possible for you to think about it. But I don't expect too much from the performance work group. They've been really focused on what is available rather than looking at future data needs. And Sally was, and some of you were in that meeting when we discussed kind of the general approach there. Any questions on the work plan? Good. So you've been very quiet. I'm hoping you'll start talking about these things on the PowerPoint. What I hoped is, so I'm going to go through the PowerPoint, but as I said, this we kind of are envisioning this as our draft version on a PowerPoint. And feel free to stop. I have some stuff that I planned so we can have the discussions. But if I don't, please just interrupt me, and then we can have more extensive discussions. So in just to recap what our charge and what our focus is, we were charged with looking at potential opportunities to use Medicare data to support coordination activities, and these can include identifying gaps in the data, you know, thinking about best practices for predictive modeling and shared infrastructure to support needs of the state, and then how it relates to the state innovation funding that we have. And in terms of the Medicare data set request, state had 2 requests. So if you hear different things, I just wanted to make sure that you are aware of everything going on related to Medicare data. We already submitted a application to get a non-confidential limited data set to do HSCRC analytical work. And that's kind of in process, and we have a pretty good idea about what we can use the data for and what our project is. So this is kind of measuring our performance targets, looking at readmissions, and comparison with the national data set. But that data set is not going to be useful for care coordination data. So that's the second data request that we are still working through our attorneys to ask for confidential data set for Maryland residents, where we will get the files and then do what we need to do for care coordination. And your, you know, what we have been discussing here is really that second piece, and it's just since the data structure takes time to, you know, implement and coordinate. This group has this challenge of not knowing exactly what data is going to be given, how it's going to be used. So we are kind of putting our prediction tools in our mind to think about if we get the data the way we think we are going to get, and a general concept of what the care coordination strategies need, what are the things conceptually we need to kind of advise the commission to start creating infrastructure. They're going to try to mute. Those who are on the phone, please mute yourself as well. Maybe that will help, and it did, sounds like. And the reason why we had the joint work group meeting was, try to get a better understanding of the care coordination. But as you all know, there needs to be more work to be done to try to think about those care coordination strategies statewide. So we stole the we are never shy about plagiarism here. So we stole the slide from Dean Farley from that presentation, and I think everyone kind of agreed that this was a very good representation of what we need. So what we are kind of seeing this and adapting to our situation is in the top middle part there is the health plan. And I think with the new waiver, it's no longer just the health plan, it's the providers, it's the hospitals, and we need to find a way to create that clinical analytical platform that could address different needs of these people who now have to function and do care coordination. The other, I think, issue here is the data that is available could be also different than what is available to the health plans. It could be richer in some aspects because of the clinical EHRs, and it could be not so much because health plans would have some of the enrollment data that they have. So these were kind of the background in trying to orient ourselves and focus on really, we are talking about Medicare data, we are going to get this data and where that clinical toolbox is going to come from. In terms of principles, based on our discussions in the last meeting, we put down all the principles that we had before and adapted them based on your comments. So this is the place where I plan to stop and kind of discuss if these are enough, or are we, should we add other things or modify them. So the first one is the Medicare data should be transparent and accessible to different providers. Gaps in Medicare data should be addressed, either through other data sets like HIE or DHMH data sets. Hospital providers and policymakers should work collaboratively. And achieving population health goals will require exchangeability of the data among providers, and that the data infrastructure should promote partnerships among providers and systems. Are there other, so collaboration, transparency, identifying gaps and making it more useful. We are either doing a great job. All right, I'll take that. So, option A.
So I wanted to just share a thought. So the idea of having these discrete pieces, I think, is the principles are correct. And I think the idea, at least when we were working through SIM and the thought around the public utility, is there needs to be an articulate and deliberate data integration role. And when you think about all of these pieces coming together, we can all use them from whatever purpose and whatever perspective we're coming from, but it's really that working together across the continuum of care to ensure that that patient gets what they need. And so that concept of data integration, somehow bringing that information together and bringing partners together to be able to reflect on that, is how we're going to be able to have that drive towards action that will then lead, hopefully, to better outcomes. So I just wanted to add that thought and maybe get other people's thoughts on that.
I think what I hear when you say that is that it's more than just having the data and the infrastructure in place, but it's having the relationships too. And I think that's a good principle.
And maybe, I know that the local health improvement coalitions were designed to sort of pull groups together, and that's worked better or worse depending on where it is. but the idea that there should be someone in the community or the whatever area that we're covering that has the deliberate role of bringing folks together and talking through what does this data mean, what does it mean for you, and how's that going to work, and what does it mean for us, and how's that going to work. So I just wanted to put that out there.
Yeah, we did try to kind of separate the attributes, and we tried to get that a little bit in the have independent and broad-based governance when we are structuring this. I think the idea about, yes, we want to do the bringing together in the data, but you really have to bring people together first to identify those needs. I think, right, very good point. So in terms of the desired attributes of the infrastructure for the Medicare data, as I mentioned, have independent and broad-based governance, ensure data security and confidentiality, be efficient and scalable. So again, once we have better idea about the care coordination, here what we are meaning is you don't want this data utility to do only one thing and only one thing. You need to make it as scalable as possible so they can accommodate different needs of different providers or different patients. The fourth one is provide access to data and analytical tools to providers with varying levels of capacity, including hospitals and non-hospital providers. Have the ability to easily integrate with other systems while maintaining patient identity integrity across those systems, and then be flexible to support different uses of data. So the curve that we talked about, right, having multiple models on one hand versus one model, the medium term, that flexibility versus uniformity, collaboration, we are trying to get that, yes, you have to have a flexible infrastructure to accommodate the variation, but at the same time, you have to have that infrastructure to coordinate these models.
Can I make a quick comment? Gene from MedCai. I don't know if this is an attribute or a principle, but should we put on there somewhere that we should make it clear that we want to maximize the investment the state has made in CRISP, and they've done a really good job. It's probably the most successful technology program the state has ever run, and we've got all this investment, we've done all this work, and it doesn't make sense for us to recreate the wheel. So we should highlight that in one of those two places and make it clear that we're going to try to maximize the use of that and not rebuild something new. I think that's important. I don't know, Scott, where you'd rather have it.
I mean, thanks for the compliment.
Scott, Michael?
Well, it's kind of a low bar. The successful technology project is not, that's not saying much, but you guys have done a good job.
Well, we're obviously certainly, as we've said before, we're certainly interested in that role. We've been positioning to make sure we understand that role. Whether, I think we kind of, as I look at these things, I think we fit this mold well. Whether the group is comfortable explicitly stating that is kind of up to the group, but I think we've certainly supported.
I think
Not really surprised there, Scott.
Ben, microphone.
I think that what I would maybe say is use. Just a second, I'm gathering my thoughts, so you'll only hear stuttering. So what I would say is, like statute, principles probably shouldn't be specific to one entity. So I would say try to emphasize reusing existing capabilities to the extent possible, because I do think you would want that broader. UMBC, for example, has enormous capabilities in the context of the Medicaid program that are going to be key in the interim as well. So I would argue for a broader concept rather than use reusable capabilities already established by the state to the extent you can.
I think we should mention CRIS specifically. I mean, you guys run it, frankly. I mean, aren't you the regulatory body that helped set it up? I mean, you should be proud of what you've done. But no, I mean, that's really where mean, they're the ones who do most of it. I don't mind mentioning other groups if it's logical or adding the language to catch the others, but CRISP is where the rubber hits the road and where most of this stuff is going to happen. And they're doing some of this stuff already, so I think they should be mentioned, and I think we should just be straight about it here, and we should work with that, you know.
But I think that's a choice, not a principle.
Well, let's put it under
So what you could say is, you know, according to the principles, they fit that role. Right. But if you do it the other way, it's sort of...
I think it should be mentioned in the report. I understand what you're saying. I get your point on the principle. I have no problem with using Ben's as the principle and then mentioning Chris specifically in the attributes. But I think we should talk about what Chris can do in the report, what Chris is doing in the report, and talk about that as being part of the plan as we talk about implementation and going forward. I think that's important. Because I don't want to see a situation where down the road policymakers look at this report and then go, okay, let's create a new program and let's figure out how to do it, and then we start over. And you can see that happening here. I mean, you're laughing, but I mean, you know, I'm serious. We've seen this before. So we should say, look, this thing is working. It's done a good job. Nothing horrible has happened. There are multiple other technology projects with the government where I can show you that there have been bad things that have happened. So why? And they're doing a lot of stuff we need them to do already. Why not expand on that? And let's be, you know, I get your point about the principle. I think the two of you are right about that. The principles should be general, but I think in the report we should talk about Chris specifically, what they can do, and the thought that that's going to be part of our implementation plan. And maybe it is an attribute or another section altogether, but it should be in there.
Yeah, I don't think that's unless other people have more comments. I think probably I would suggest referencing other contracting organizations, including, like I say, UMBC and others, because...
Which others? The Health Insurance Exchange?
No, I'm talking about
I think
facilitators. I think UMBC would probably, if they were here, would say we somewhat fit that role. And this is not anything against Chris. It's rather that if you only target one, you just create more problems for yourself. And I would say that.
Well, which other ones should we have? Why don't we say? With that, I'm fine. I think UMBC makes sense. We could put them in there too for what they do. That's logical. Their website is there's some helpful stuff there. But I think we should talk about which ones we want to mention in the report and put them in there specifically. Who else did you want to put in besides those two? I think that's the other one that quickly came to mind. And if Tricia was here, I think she would say that they've made a pretty big investment in UMBC in terms of their capabilities. So,
you know, while I certainly agree with Jean, I've worked with Chris and I've worked with UMBC both successfully, but I tend to agree with Ben in the sense that we probably ought to keep it name agnostic and more of a broader reference. One reason is, right, CRISP is owned by it may have another iteration, another life, the same organization, but as we begin to expand what we're doing, you know, it may take a different form or shape, and so I wouldn't even want to, you know, narrow the opportunity, but I agree. We definitely don't want to reinvent the wheel. They've done a phenomenal job, and don't want to do that, but I think we ought to keep the language broad.
I'll speak up too. I think it's fine if we want to mention both. If we mention organizations, it might be helpful to talk about what attributes each has related to our principles. We talk about governance structure, access to data, who's doing what. I don't know if that's helpful.
I would split that actually. Okay, you know, if you want to be agnostic about the name, we can discuss this in the June 18th, but in terms of attributes, to me, we were going from this angle first, and then, to me, one critical element that we didn't mention in the data infrastructure, whatever we are building in, I would argue that we have to link it with HIE, whether, you know, then you can think about, okay, does it make sense then to have those links in a more closer way, or if your attributes are not really, you know, fitting in the existing CRISP, there are two options, right? You can modify CRISP a little bit to fit in the new role, or then you'd look somewhere else, but then you create the, then the new infrastructure, which, so I think to me, you need to start from the opposite end to think about what attributes you want and clearly identify the need with the
point, Shule, I think that if you look at the second to last bullet, some of these things are kind of embedded in there. To Ben's point, I obviously would advocate for Chris playing this role. And I think in reality, if you're looking at how the state's going to practically execute against the things that need to happen in the relative near term, probably is not a good alternative approach. But if you look at the really specific things around identity integrity across data sets, I literally think there's no alternative. So I think they're already embedded in some of these attributes, and to achieve these things, whether they're at the conceptual level, as Ben said, or the really specific level, they're laid out here pretty well.
I think I would like to add a specific that it has to be linked with the HIE. That to me is a data attribute that we have to make it more actionable and used. Because you need to get this information, whoever is doing it, you need to get that information to the boots in the ground. And we went into this investment and create the HIE to do those exchange of information.
Maybe we go a little, at least deep enough to say the state designated HIE.
Mm-hmm.
Can I just highlight one thing that you just said, Shule, that I think was really important, is that it's not just the data, but it's the ability to act on it. So I don't know if we have that in our principles or attributes, but just to have a data and have an analysis, great. Your planners can look at it, but you need to push it out. You have to have the ability to push it out into a workflow to really make it useful.
Yeah, I wanted to go back to page 5 to the next to the last bullet, because I've been sitting here trying to think about our conversation at the last joint work group meeting about how we defined exchangeability. And I've just been sitting here trying to ponder if there's a better word or a better definition, but it needs to be more than just, Scott, maybe you can help with, you got to be doing more than just exchange it, and Tracy made one of the points, it's got to be actionable. It's also got to be accessible, easily accessible.
How about interoperable? Another overused word.
Yeah, okay. But I mean, we've got to be able to get it in a very timely manner so that it's actionable. So interoperable is.
Yeah, that needs a little bit of.
It's more than exchangeable.
So you're talking about having it and being able to take action.
To Tracy's point, which is a good one, that it's not just used for performance monitoring, whether at the system level or individual hospital level, but used for clinical decision-making, care management decision-making, intervention-oriented purposes as well.
So that's also more than interoperable.
Right.
Yes.
Right.
So
we got to go another step.
right. So we did this. We were trying to really isolate what we were talking about in Scott's. This is the visualization of what you said, I think. And we are really looking at the bigger one, the clinical, the actionable data. In the policy level one, HSCR, as I said, HSCRC asked for the data, we're going to get it, and it has different needs. It's definitely, you don't need it in real time, and Frank is. That's free,
we've been engaged with Chris for a number of years. Oh, sorry. Sorry. We've been engaged with Chris for a number of years, and it's extremely actionable. I mean, we started with the ENS system, and I am a big fan of the system. And I think one of the principles is we want to really preserve existing investments. If we think those investments are good, I mean, you want to preserve that investment and develop it. I know I've spoken to HIEs in Delaware. I've spoken to HIEs in Philadelphia, in the eastern region of Pennsylvania. And we'd love to have the same capabilities. Whenever I talk to an HIE, they're always trying to, make a sale. It's almost like they're trying to convince me. I said, look, you don't have to convince me. I mean, I'm a believer in this, and I think a lot of that has to do with the fact that it is actionable data. We used the ENS system originally. We have a query capability now where our people can go in, our health services people go in and look at actual results. Okay, our physicians, we've signed up our physicians on CRISP. It is very actionable data, and it's just a question of, can you see, when you look at this, how valuable it is? Right? Do you understand the content of a hospital medical record? When you go to a clinician, when a clinician can go online and pull up an MAR, a medication administration record, and see what's in that, or when you can go online and you can pull up a member and see what visits they've had. I mean, I simply would say, we really want to preserve existing investments where they were. I haven't seen the other one,
UMBC.
the UMBC.
Yeah.
I don't have any experience with that, but the experience we have had has been very positive.
Yeah, I know it's a completely different set of functions that they perform.
Yeah.
So, yeah, probably not interchangeable.
But it's kind of like Linda said at the, the Wednesday meeting of the commission. I mean, this is actionable clinical data. The claims data.
You're going to get me into trouble here, Frank.
Oh, sorry.
I think what I said at the meeting, just so my boss doesn't smack me, is that claims data I thought that claims data, because of the time lag, was really best suited to system management. And but probably not, most physicians wouldn't find the lag in claims data useful. A physician wouldn't find it useful for patient management in real time. That's sort of not. They serve.
Right. No. I mean, just the ENS notification. Okay. Members gone to hospital ER. I mean, we know it. Within minutes of it occurring. I mean, it gives us an opportunity to manage it. Right, which is what we're in business to do, is to try and manage healthcare. I would just, the principle, yeah, we want to preserve an existing investment. We have a positive, return on those things. I just don't think you want to get to a sense where everything becomes fragmented.
No, I think we're all in agreement. I think that can move along.
And there's still a lot of upside to this. I was with a doc last night who had just signed up, and he was using PDMP, and he caught 2 drug seekers this week. And I mean, we were talking about it, and these are people who are going to get a different kind of treatment. That one was seeing 3 doctors, another was going to other folks, and he caught it because of CRISP. And I think right now, what do we have as far as ambulatory providers? Maybe 700 in the queue, and maybe 300 or 400 signed up. So we have a long ways to go. So there's a lot of upside to this too, and we haven't even started. I mean, we haven't really got nursing homes or AMSURG centers, and that's another big potential opportunity. So the idea that we would then go create something else, and we have something that's working, and we still have a lot of folks to get using, doesn't make sense.
Yeah, I think there's a lot. I think Scott would be the first to say there's a lot of upside.
This is one of the few technology things too that I've heard my members say positive things about. They don't like 3MRs. They don't particularly like any of this stuff, but I hear them see value with this, with the ENS system, the portal, and the PDMP. I've heard the most positive about PDMP, frankly.
So, I mean, I think we do want to be dry. I want to drag everyone back here to the. You're talking about Medicare. Are you talking broadly about data? Or are you talking about what the Medicare data can deliver?
So we are really focused on Medicare data, but you would think that because that's our priority, and payers, Medicaid is using UMBC to do their, and the MCOs are doing theirs. But for Medicare population, we do not have any clinical tools, right? And we are going to have 330 million savings.
Right.
So
for stratify without getting access.
Right.
And I think I'll just say the point that would bring those two together is, even though Medicaid uses UMBC to do their data analysis, that using UMBC to do that, they don't have connections out with the provider community. So it's just can sit there for Medicaid, whereas I think what we're saying is having the claims data, albeit it's going to have a lag in it. There's also other data within CRISP and other functionality that when you combine those two, it's very powerful. And I know hospitals really like that and find value in that, similar to what Jean's experience with physicians is.
Do you guys know what the lag is yet? Do you know if the request could be for a more frequent set of data to come over? I mean, because if it were monthly, every other month, whatever it may be, you could do some clinically relevant things off of that.
Right. I mean, it's going to be monthly, but because of the run-out problem, I think it's going to be 3-month lag. That's my understanding.
I think it's just the normal claims lag. That's all.
Right.
Right. It takes about.
Sally, could you use the microphone?
It takes about. I know at Priority Partners, it's taking us about 6 to 9 months to run out claims to the fact where we've got fully mature data. So, and we pay claims in 5 days. And it still takes 6 months by the time you get all the enrollment retroactivity reconciled, and then you get all of the appeals done and all that reconciliation before you really have clean, attributable data. You can't really use it for clinical decision support.
I do. I mean, it depends on what you're using it. For example, I know for readmission percentages, risk-adjusted readmission, RTI developed apparently a methodology where they take into account that missing in the last 3 months missing claims, and they give you a close to real-time readmission rate. So there are some methodologies to close that gap in the data too. So it kind of depends what you use.
Well, we do that, but we do that with our own tools that we built. We built our own decision support tools and factored in things like claims lags.
Yep,
stuff like
exactly.
So it might be useful to think on keeping the focus on the Medicare data. What can it be done with today, or 3 months or 6 months from now, recognizing there's probably going to be a 4-month lag, and what could be done with, next step 2 and step 3, because I think you can hope for, yes, the data would be delivered more quickly, but I think the experience from some of the ACOs and some of the Medicare multi-payer PCMH programs has been that CMS struggles to meet their commitments even within the windows that they promise. So rather than create a vision in the short term that can't be achieved with the Medicare data, the focus might be to give CMS their due and say, we're going to assume that it's going to be about 4 months lagged, and what purposes can we make with the data as it sort of, if you're a golfer, if you play it as it lies, rather than anticipating, if only we could have it in 3 weeks, if only we could have it. So I think that, there are efforts, I think within CMS they would tell you they want to do it faster, but rather than counting on that at the outset, we count on what we think from other programs and initiatives has been able to be achieved.
Right, and I think the task we have is the advisory council prioritize going on high utilizers, high risk patients. So assuming we'll get the and these models are based on historical data, right? So and we are asking for, I think, 3 years of data to be able to run those predictive modeling. So if you think about that as kind of a single most important task, where I think the infrastructure, the conceptual model we are trying to work out is where would that analysis be done? And we are not thinking at this point kind of cutting those claims out and sending to whoever is requesting, but creating this platform where these analytics can be done. Sure, if they want the claims level data, you use this platform to get it for Medicare claims within the use cases for the Medicare data rules. But at the same time, create this, start thinking about it and start building about the platform where we can have these high-risk users identified. And we did list, that's kind of the first one, and then, we start thinking about what are the other uses of this data, and that comes the scalability and the efficiency part of it. This is not going to be the only thing this is going to do, and Frank's comment about building the value, preserving the value. You don't want to build one thing to do one thing. You want to leverage all the related functions and reduce the fragmentation in the system. And then, I mean, the challenge I think we have as a group is that we really do not have, apart from high-risk utilization, we really don't have a good understanding of what the other use cases are. And in our report, most likely, our report is going to be more conceptual and kind of clear guidelines about what this infrastructure attributes and the model should look like, and then identify things for the next step to work on. And for us, for example, once the care coordination discussions are going, think about, okay, who is going to use this data? What are they going to do with it? Things that you think are important while thinking about and building the infrastructure that you need the answers to be found as quickly as possible. And in that sense, the potential use of data, we list them. And then the assumption list, kind of, even though we don't know what it is, we still know that there are some common elements in all care coordination interventions that you can easily identify and start thinking about a system that could help produce those needs, and also be aware of that the needs, again, we're thinking about care coordination and the boots on the ground type of analysis and help hospitals. So because of that, it has to be timely, it has to have the targeting approach to it, and then most importantly, the data at the right time and at the right place. And I think that's where Chris' role is critical here to make that happen, rather than and that was your purpose, right? Yeah. So we need to come up with a conceptual model in the report, and these are the things that we pulled together. So I'm hoping we'll get an agreement on it, but the first one is the Medicare data should be hosted in a shared infrastructure that can include other shared data sources. And I think we've been discussing this for a while, and I think we're all in an agreement on this one, right? Then the focus attention on high-risk Medicare patients consistent with the recommendation of the Advisory Council. And the shared infrastructure provides data to support varying levels of needs. So we try to preserve the balance here again with different needs from different providers. And to promote transparency so providers are working from a uniform understanding of data findings. And that kind of, you need to have the governance, and even selecting the tools. You don't want to create an academic council and evaluate all those and then come up with a solution that providers are not going to find useful. So the structure has to have that relationships built in, that they are still already working with the community to come up with these tools that will be most valuable to them. They may have the highest predictive value, but if it is not implementable, that's not going to work.
Could you set an angle on that last one? Because we've had, as Chris, some specific experience in that as a challenge. When we first started creating our inter-hospital readmission reports, we did it using some logic that we created internally. And that came up with a number that was slightly different than the AR number would look like. And so those different methodologies caused a lot of confusion in terms of what's right, what numbers do you work from, and everyone would like to work from one uniform set of numbers. So that ability to have kind of a single uniform understanding of a given metric, knowing what methodology was used, is really powerful to reduce the cycle time of getting to a conclusion on what's what if everyone's trying to run it in different places and get to the same place.
Any other kind of attributes for the conceptual model if you're thinking about this entity? So be the shared infrastructure.
So I guess I would be somewhat, I think that point that Scott raised needs to be nuanced a little bit. That there is enormous value in single sources of truth where there's agreement on what that truth is. But there's also, and I'm thinking of the predictive modeling framework where I can see a lot of different organizations may want to experiment. And part of the organization's ability to differentiate themselves in the market is built on the belief that they can identify and build or acquire analytic tools that are of value to them. And I think there are some absolutes, sort of the moonshot, where the moon is, but you have to recognize that by being too prescriptive, you can limit innovation and actually create enormous strife where you do maybe benefit from having some flexibility and innovation. So I think separating absolutes from areas where flexibility is warranted is important to distinguish. And I think the predictive modeling area, where there's, if I had, so RAND has one, RTI has one, MedStat or the predecessor to MedStat, Truvon has, they all have their predictive models. And I think Andy, they've elected at CARE first to go with one predictive model. Frank has probably elected to go to it with a different one. And once hospitals get in this business where they see value in this, trying to force everyone down one lane may not yield the result we hope, because we don't know truth, but we also may not build alignment where it's beneficial.
I think we are all in agreement on it. What we are providing is a capability to produce those predictive models. If a hospital wants to take the claims and then for their competitive advantage, they want to work on their own, great, go do it. But I think there is some agreement, and advisory council really warned not to go too far deep in terms of innovation and find the useful things that are already being done. I think in the infrastructure, maybe we need to flesh it out a little bit more, where we have the varying levels of need. This infrastructure also kind of a clearinghouse or best practices place where they produce, like we pick the PQIs, right? We've been using the potentially for our potential avoidable utilization. We determined that what our Agency for Healthcare developed in terms of avoidable admissions, we took that because it was public, we were producing, and so then it's now going to be used by the hospitals. They're not going to go and try to come up with, they will have their own ideas about what is avoidable, and they're going to go and try to do those as well. But at least we now have a standard for a lot of the hospitals who would, rather than investing in measuring, they're going to go and try to reduce their PQIs. And I think that's the same analogy with this one, that we want to create a shared resource where they would pick, with the collaboration with the providers, they'll pick 3 or 4 predictive modeling and then produce them. That, I think, but we are not saying you have to use A, B, or C. I think I agree with you. I don't think the needs of the providers is not going to be that uniform that you can.
I guess the way I would say that is, sort of the clear standards and objectives with flexibility in the methods on how to achieve.
I would agree. The other thing I might add to your list of things that are uniform are things that are related to payment. So like in the readmission example, having one source to produce, here's the answer for readmissions for this quarter. That's helpful. But to have something else where you're making decisions on, that's where the flexibility comes in.
Then if that's the conceptual framework, have a shared resource and have flexibility, in terms of our report, what are the tasks that we need to start working on to achieve that conceptual, to make that a reality? And in terms of that, we consider them as implementation tasks, and the first one is to define specific data needs. That we would encourage the next step to be able to focus on this questions. And here, the who and what question, and then also how we are going to identify promising predictive tools that could be produced by this shared resource. Any other data-related things that you would want to add to it?
I would just say, how are their needs similar and different? How are their needs similar and different? Everybody thinks they're different. We spend a lot of time trying to accommodate differences. Start with the similarity.
Focus.
And I want to keep dragging myself back to we're talking about Medicare claims data right here.
Yeah.
Okay. So keep that.
And I'm not representing them or shilling for them, but we should probably just add nursing homes to the list if we're talking about Medicare. We should just put them in there, and they might have specific needs. I don't know what they are necessarily, but they're our friends, and they're not represented here. So,
well, yeah. I suppose if we want to get specific in terms of all types of entities that serve Medicare populations, you need to add, home health agencies,
hospice.
Yeah.
You don't even like saying the word.
The list was kind of. So, do you feel that we can list all those, or do you think that more work needs to be done? Certainly, we can list all. Different types.
I don't know that you want to list all, but I think you wanted the big ones, particularly if you're worried about the $330 million magic dollars that we have to find. Yeah. You should hit the ones that are Medicare related.
Right. So the idea here was you were saying to the next, like in the next discussion, we are going to end our report. When you are thinking and building this, you were saying it's important to identify who these different providers are, rather than us coming up with the list. But what I'm hearing from you is that since this is Medicare, we know who the providers are, list those in the report, and then say, question for the next step is just to make sure you are not missing any of the important ones. Is that what I'm hearing?
That's what
So,
okay.
yeah, when you think about it, you've got a continuum of care. Right? You've got this large continuum of care. You've got ambulatory services, call them pre-acute services. Okay, somebody hasn't gone to an ER, somebody hasn't gone to an inpatient stay. Okay, so you have, and within that you have clinics, you have doctors' offices, you have ambulatory surgery centers, labs. You've got a $2.7 trillion industry. It's got all these participants in it. So you've got those services. They have certain needs to maintain the health of the population, okay, and promote the health of the population. Then somebody goes into an ER for something, okay, needs some urgent care, or needs a hospital stay. So you've got the acute set of services that are going to be provided. And then you've got post-acute services. All right, so you've got hospice, you've got skilled nursing, you've got home health. Okay, and you have special populations, people with end-stage renal disease, people with disabilities. So it's across the continuum. I think everybody has a data need across that continuum in terms of managing the scope of their clinical service and to do that well. So, I would say across the continuum of care, because at the end of the day, 5 years down the road, it's population health care management. Right?
I think that's exactly true, Frank, but I was also thinking, the point is to focus on the high flyers. So I was thinking about, in a privately insured under 65 population, less than 5% of the people have an inpatient stay, so it's hardly anybody. But in high flyers, most of them are going to hit the hospital, or they're, so some of it is you also want those people who are the other people in your continuum not to be, I don't mean to be wasting their time on the people who are, just anyone who walks through the door, but I think there is this prioritization where you really want people to use their resources where they'll get as big a bang for their buck as possible. And so there might be, that question of how you get people to coordinate, everyone to coordinate around somebody identifying the high flyers, whether, because each individual hospital could.
I absolutely don't disagree with that. I mean, when we look at a Medicare population, if you look at our population, 25% of it's under 65. Well, you've got disabled, you've got chronics, okay, you've got people with mental disability. I mean, that population, and you've got to manage that population. You've got to identify those people because the interventions are going to be very vastly different. I mean, the intervention for somebody like me, healthy, ambulatory, can drive myself back and forth, et cetera, But if I had a mental disability, I mean, it's a completely different intervention. It's a completely different set of clinical services to get those people up and running and in a healthy state. So I don't disagree with that at all. I'm just, when I tend to have this thought process that goes here and then goes there and then goes, today and the future.
So in terms of identifying who, you want to make sure you cover across the continuum. That's what you're saying?
Yep.
And then you're saying, but we have the focused high-risk population, so you need to acknowledge that you cannot provide the needs of everybody who are involved in the care. You really tailor it to the population that you're identifying. Make it clear who those points are in the care. Did I get it right? Cool.
And I would only add that you have DHMH, local health departments, potential SIM hub. There might be entities that hospitals or other organizations are working with, community-based organizations that might not be the hub, or if the hubs never exist. But I would just add other entities that specifically work in care coordination and other types of transitions of care. So, and then to the extent that we're talking about these high utilizers, then we go down the road of the social determinants of health and think very clearly about not everything that's going to work for these folks is a clinical intervention. So there might be opportunities for the Department of Human Resources or another group, Department of Aging, to be included there. And I think we would really miss an opportunity if we didn't think more broadly about who's using this data, to the point about being actionable. When these sources of data are brought together, you need somebody, and that's my term, data integrator, to bring these things together so you can determine, what's going on here with this person or group cohort of folks. So I would just put a plug in there.
I think that raises the issue of there is another type of data infrastructure which Massachusetts and several other states have pursued, which are really the integration of Medicaid care data and all the social data, so they can pull up a person and see if did they not get care because they were incarcerated, what all the interventions the state has brought to bear on their Medicaid population, so that this is that population there, or their social services population. And so that's, they've, like in Massachusetts, they committed their big data infrastructure is to have all that information at anybody's fingertips, so that a physician can pull it up and see what other resources the person has been accessing or what they might have access to, so that it's completely coordinated. And there are several states who are doing that, and that's their really big thing, is to make the state data systems talk to each other and to be integrated. So that's a different type of infrastructure, but
So I
Talisha Cunningham. I agree with everything that's been said. I'm just curious, when you start to list providers, the use of hospital discharge planners, hospital CMO, is it our intention to be that specific versus simply say every hospital needs to be able to access this information, and whomever within the hospital is designated, whether it's finance, whether it's a decision support function that's helping to drive the data within the hospital, to our clinicians, because that happens a lot too, where we're actually pulling the information together and sharing or linking the clinical and financial data. So just to make sure it's broad enough from that perspective.
My intention was just to alert that once we have, and we did define the conceptual model for the implementation, you need to define who is using it. And those were kind of, to me, examples of the people that you need to think about. And I think we can make it broader list and say, here are the group of people that could potentially use this data. But once we start building this infrastructure, that's a specific task. We need to go about and really identify who those people are. And within the hospital define who's going to use this data. Yeah. And for what purpose.
Yeah, as a couple people, are talking about a really wide swath of data. I want to again say we've tried that. We recently tried that. From my judgment, some of the challenges with the exchange were related to data integration. So I would again strongly recommend that you rank by priority what it is that needs to happen. And you're talking about Medicare data, and the fact it would be nice to know in that sort of portfolio of people. Yes, does the person get food stamps? Yes, do they get energy assistance, et cetera? What's their status in their home situation? How many? All of that is valuable, but it's not achievable in the next, whatever the first time frame that we would like. Given the fact that the data infrastructure in Maryland has not been invested in adequately for several decades, and the challenge of this is that any one initiative that tries to take on, we're going to enhance the data infrastructure in Maryland, will fail by itself. That's my opinion, but I think that's recent facts demonstrate. Trying to bring everything together at once is really challenging, so you pick and rank your priorities.
Right. I think the second question, what data is most needed for care coordination? If you want, we can make that for Medicare population if you want to make it more specific. But I don't know, when I go and present Maryland system outside of the state, I say we have two great infrastructure, all-payer system and health information exchange, and I consider investments in there as data infrastructure. That's different type, but I think that we fail. I don't know. I wouldn't agree with you on that, Ben.
Well, I guess I would yield to.
Yeah, I think it's in the eye of the beholder.
So I don't think that the general view would be that Chris not aside, but we haven't invested like a lot of states have in IT infrastructure. There's no doubt that that's the case. I mean, I think that's just reality, and I think
not everyone has all-payer claims database. They've been trying to build. We've been. I mean, don't.
No, I'm not necessarily. I don't think we want to get. I'm distinguishing between the nuts and bolts of a data system. We do have databases, but do we have integration among? Back to the point that someone was making, do we have integration of social services data with healthcare data? No.
Yeah, that's a different.
Those are the questions that you're raising here, and those are some of the challenges that the rocky shoals of the exchange ran into, and that were really laudable goals of trying to, a single point of entry, et cetera, required integration of the EHR data.
Right.
Data.
Again,
and that's what I'm saying. Just recognize there's a transition.
Yes, I think yes, it's great to have this vision, but then when it comes down, we are talking about care coordination. We're talking about Medicare population. We are talking about creating analytical tools in relation to the care coordination. I think we need to always think about our immediate needs and try to build from there. So those are kind of, to us in the report, we were saying, okay, make sure you start thinking about answering these questions rather than us answering it, because it's a chicken and egg issue a little bit. It's really hard to think about the data needs without really having an idea about care coordination. So, and we've been trying to link the physician alignment performance work group with you guys, but at the same time, there is a point where you can go before the other work groups come to some kind of direction for the state, and I don't think we are there yet. Then in terms of the, once you identify the needs and people who need the data, the issues around data sharing and protecting privacy. So since we are talking about Medicare data, depending on how we request that data, we are going to be bound by those privacy rules that the CMS is going to have.
I'm really curious about sort of what, is a Medicare patient walks into the doctor's office and suddenly the doctor makes it apparent to them that they know all sorts of things about the services the patient has used. I mean, that would flip me out. But so can that happen? I mean, does Medicare make you get permission from Medicare patients to make that happen?
I don't know. Our lawyers are engaged in those discussions, what we can use, what we can. And they also, CMS asked us, how are you planning to use the data as the question? And I think it's been worked out. Anyone from CareFirst, I don't know how they are using the data, but they do get Medicare data, and it's linked with their providers, right, for the PCMS?
So, I don't think that I have any knowledge here other than to say that for everyone, maybe we think about what the model CMS has allowed for ACOs, which is the patient has to agree and has an opt-out opportunity. And I don't want to foreshadow that, but probably that's likely what the state would have to operate under this apparatus, that a Medicare patient ultimately decides, and if they want to participate, if some of the same ACO type arrangements would exist.
Well, they are in unless they opt out. They get notified. It's very specific.
Okay.
There's a letter that CMS has that you have to send to them for the ACO, and then they have the option to opt out if they choose to. Very few do, from a practical point of view. We're involved in several of these. They don't opt out.
So I think, without debating it,
there's a few more in the conservative areas where they think.
Right. So, but I think the point here is whatever data we get is going to be governed by the rules of CMS and Medicare policies. And then, we have the existing, and then on top of it, there are existing federal and state policies that will govern some of those data exchange. And at this point, I think in terms of what we discussed in the last meeting, those two would be main at the initial phase to think and try to apply and live under. And as we try to add new data sources and new uses, then there might be a need to assess the gaps in those policies. And then once it's assessed, get a legal reviews and then and the policy board's inputs into what other additional policies that we need to implement with this data, if it makes any sense.
Julie, I would just add the HIE policies to bullet number 2.
I like your suggestion of getting some kind of counsel or advice when it's the appropriate time. I think investing in that would be a good suggestion before we start sending all kinds of stuff all over the place, because then we can avoid a lot of problems and make sure we're compliant and protect patients' privacy and things like that. And I think that would be money well spent.
Yeah, to Sally Ann's point, I think there's already some discussion underway in the HIE policy board under a lot of these questions.
But let's say a miracle happened and we got the data tomorrow. What I'm kind of, we need to get the legal counsel, but with the existing rules that they have, we should be able to use that data for whatever we're approved for, that we wouldn't probably need additional policies to be implemented for Medicare data.
I think absolutely where it's clear, but it's increasing. There are lots of areas where it's not really clear, and transmitting, in the case, information to a hospital that's in a service area or a patient in that hospital service area, never having seen that patient, those are going to be some.
But
sounds like you are saying the same thing, Deborah.
Yes, yes, and also
we need to move forward, get the legal opinion, see what we're allowed to do, we're not allowed to do, and then on the issues where there's confusion, we send them to whatever committees they need to go to.
Right, and also
making sure we're protecting patients' rights and doing what we need to do.
Right.
But we're moving forward so we can start saving the magic $330 billion that we're supposed to save.
Thanks. And also, what I was saying, Medicare rules are trumping any other things we are doing here. So if we realize we need to get an exemption, that's going to take even longer to get it. Yeah.
So we're all in agreement. That's kind of where we're going, right? That's the recommendation or whatever. You'll make that all happen in the report magically.
Mm-hmm.
Good.
We'll write that on. We are recording these meetings. I told you, right?
I just wanted to follow up on Ben said, because Ben said that the CMS rules are vague. I mean, I've worked in Medicare for a number of years, both at CMS and Medicare Advantage, and their policies around data use and consumer protections were always very clear.
Well, I think I was talking specifically about some of the issues that have been generally touched on at the HIE policy board, where I said we were talking to the AG's office on, which relates to, does a hospital or some of these population health issues have access to the data, and we're talking to the OA office of the Attorney General about that.
Okay.
So
I thought you meant that CMS was unclear about those
specifically about the population health model.
Yeah.
I think that your attorneys have been in that meeting.
Well, they're a lot clearer than anybody else.
Yeah. And Maryland has a specific prohibition on CRISP use of the data, which might add a level of complexity to this too. But we don't need to get into the weeds. I think that
because we are the MHCC and and de facto CRISP have pretty broad policies already. Have policies already approved on the primary uses, which is what we'll be using this for. We're struggling now with some of the secondary uses and the gray area stuff now. So,
yeah, I think we don't want to get too much in the weeds. The policy boards.
we do that well enough.
All right, so that kind of concludes what we planned. So the plan is, based on your input and the comments, we'll try to put them in writing and then move from there. Any other?
So you're going to you'll send a draft report out to us via email so we can look at it and comment?
Yep, certainly. And I think I would encourage you to send the comments via email so that we can update it and bring it to the, we have time for June 18th, so we'll try to get the draft as early as possible.
Maybe when you send it out, you put all of us in the email, so if we respond, we could respond to everybody.
Everybody? Okay.
And then we could all see it, and then maybe we could speed this thing up.
That's great suggestion.
And then we won't be wasting a lot of time working.
All right. Great. Thank you very much, and have a good weekend.
Many points.